Yeah, it's my great pleasure to introduce Professor Paul Fockens, who's the chair and professor of gastroenterology at the AMC Academic Medical Center of Amsterdam. And he's here going to talk to us on another new technique in interventional ERCP, that is endoscopic papillectomy, ampulectomy. Over to you, Paul.
Thank you very much, Amit. It's a pleasure to be here on Tokyo Live 2020 Endoscopy One. Fantastic, looks great. And I think Haru Inoue is to be congratulated. And it's a pleasure to give my presentation here. Thank you very much. Good morning. My name is Paul Fockens. Thank you very much for inviting me to Endoscopy One, the Tokyo Live Global Endoscopy Network. And it's my great pleasure to participate and to present this update on endoscopic papillectomy to you. First, as you see on this slide, my disclosures, the outline of my talk. I will talk about the endoscopic papillectomy and just briefly mention again what the difference between the papilla and the ampulla is. Then I want to talk about the trends in endoscopic removal of duodenal neoplasia, the workup before papillectomy, then the preventing of pancreatitis, and in the end I will finish with long-term results and preventing recurrence, which is quite important, of course, and I'll have a final summary. Well, let's start with the papilla or the ampulla. What is the difference? The difference actually is quite simple. The papilla is nothing less and nothing more than the opening of the common bile duct and the pancreatic duct in the duodenum. The ampulla, on the other side, is the completely sphincter apparatus which extends, of course, into the duodenal lumen, but also outside the duodenal lumen, where it branches off in the pancreatic and the common bile duct. So when you want to do an ampulectomy, you need to be a surgeon and you cut out this part of the duodenum. If you want to do a papillectomy, you don't need to be a surgeon, but an interventional endoscopist can do that. And as most ampullary adenomas are just on the orifice of the ampulla of Vater, a papillectomy is usually sufficient. Now, what are the trends in duodenal neoplasia? What we clearly see that in FAP, everything is treated endoscopically now, and cancer prevention is quite effective there. We also see sporadic lateral spreading duodenal adenomas with ampullary involvement, and they can also be treated endoscopically even when they are 100% circumferential. The cancer risk of these duodenal adenomas is relatively low, not in FAP, but in the sporadic ones. And the basic resection techniques for papillectomy actually have not been changed in the past 10 or even 20 years. Two examples. The first example on the left part of the slide shows you a duodenal adenoma, a sporadic one, very extensive, stretching out over at least 4 or 5 centimeters and encompassing about 90% of circumference, as you can see here above. And then if we remove that and we look 1 year later, we actually see, now we're going from distally to proximal, we see a stenosis, which is the cause of the circumferential removal, but you can also see there's no recurrence visible. And actually on the top here, you just see the papilla, which was way above the original lesion. So that's what we can do actually, and what we regularly do. Now this next lesion is in the lesser curve of the second part of the duodenum. As you can see, there's a lot of bile. This is typically where you expect the papilla, but we don't see the papilla. But in these cases, we just start removing from lateral to medial the lesions. And here we've done all that apart from the papilla. So now the papilla is completely isolated. We can catch it with a snare and then remove it. And we will do a radical resection. As you can see here, we did this radical resection, and we have a wire in this in the pancreatic duct orifice, and above that, with the bile, you see the biliary orifice, which we normally don't treat. What should the workup before papillectomy consist of? Well, clearly you need high-resolution diagnostic endoscopy, and it has to be done in a tertiary center. So after referral, our habit is always to start with a diagnostic endoscopy and not immediately go to the intervention. We typically use a side viewing endoscope when it's purely an ampulla, but of course, if it's a larger lesion, you also use a forward viewing scope. MBI in the duodenum is not very useful, but it is useful and obligatory, I think, to take 2 biopsies of the ampullary adenoma and to confirm the diagnosis by an expert pathologist, because sometimes the papilla looks slightly bigger than normal, and it's difficult for pathologists to call it an adenoma or just a slightly bigger papilla. Now, when you have jaundice or pancreatic duct dilation, those are alarm signs, and you should be very careful to continue, because mostly this is not an adenoma anymore, but cancer. EUS in general is optional. Of course, in these cases, you will do EUS, and we do CTs and MRs, not really following a strict protocol. We usually want an MR to have a pancreas divisum excluded or demonstrated, because it changes our management after the papillary. Again, two cases I want to show you. This first lesion, you see the minor here just on top, and you see a very large papilla of Vater, and you see it doesn't look like a normal adenoma, to be honest. But we took extensive biopsies of this lesion on the outside and also intramural, and they showed just low-grade dysplasia. And here you see the EUS and the value of EUS, because you see the bile duct, which is hugely dilated, and you see this area here where clearly there's adenoma in the lumen of the bile duct, but probably not into the out of the duodenum. Here you see the PD, which is also slightly dilated here again, and you see that there it seems that the adenoma is just growing up into the pancreatic duct. So this is difficult to say whether you should still do this or refer this patient to surgery. It's a shared decision with the patient and the surgeon, I think, whether you do this as a trial or that you just straight go for surgery. And of course, there's many other factors that are important, such as age and otherwise condition of the patient. That was standard linear EUS. This is a relatively old movie, more than 10 years old, where we use the radial mini probe. As you can see, it's going into this slightly abnormal papilla. And then when we look with the mini probe, what you beautifully can see high up in the bile duct in the middle here, if you look at the 9 o'clock area, there suddenly in the bile duct, there's clearly extension into the common bile duct higher up. You see the pancreatic duct at 6 o'clock, and then finally we go out into the duodenum. Difficult to say how high this is into the bile duct. So again, this is not really giving you an absolute answer whether or not you can remove this endoscopically. What we know from literature, both Napoleon and Retidit have published in endoscopy and GI endoscopy their series, and the accuracy of EUS is about 90%, where of course it's not just the EUS alone, it's also the endoscopic, the presentation of the patient, etc. So it's not that useful, I would say. Next subject, prevention of pancreatitis, which is important. We all put in pancreatic duct stent in these patients if we can, and if there's no device pancreas. And as you can see, that all comes from this trial in 2005, which was a randomized controlled trial, 19 patients only, and showed a benefit for the pancreatic stent. And of course, we use pancreatic stents much more liberal nowadays. This is something new, a new kid on the block. It's a biodegradable PD stent, means you don't have to remove it, or you don't have to make that X-ray after 2 weeks, whether it's spontaneous or migrated. So that's something we can consider. What about the long-term results of papillectomy and the prevention of recurrence? This is a study we published just last week in surgical endoscopy, taking together the Amsterdam experience with the Sydney experience, and a total of 259 patients, 154 with more than 1 year follow-up, and 53 with really long-term follow-up more than 5 years. And if you look at the recurrence-free survival for patients, you see that it is about 75% after 10 years, which is quite good. You also see here that actually even after 2, 3, 4, even after 6, 7 years, recurrences do appear. So you have to keep these patients in long-term follow-up. By the way, the blue line here is FAP patients, and the red line is sporadic cases. Same. This is the surgery-free survival, which after about 10 years is about 80%. So I think these long-term results are quite good, but you have to keep the patient under control. Let's go. Video, as you can see here, this papilla looks bulky. It looks a bit scary, to be honest. And this patient was presented for ampulectomy or papillectomy. I should, of course, say papillectomy. And well, finally, we decided to go on with it. You see, it's not that big. It's maybe 2 centimeters. We take our standard, relatively small snare and wiggle it around the lesion. So it takes some time. We shouldn't close the snare now. We should really, really carefully wiggle from left to right and right to left until the snare is really flush with the duodenal wall, as you can see it here, and then we will remove it. We use endocut current with a normal setting, actually standard setting, unless the lesion is very, very big. And as you can see here, when we come back after removing the specimen, taking the specimen out, clearly it doesn't look good because you see adenomatous tissue in the mouth of the bile duct, quite clearly visible. So we did a sphincterotomy, a biliary sphincterotomy. We removed some with the snare, and we also did some APC. And finally here you saw the guide wire go into the pancreatic duct. And we're placing this Archimedes biodegradable stent here in this patient. Slowly bring it into, of course, under X-ray guidance, bring it into the pancreatic duct. And then because of the coagulation at the site of the biliary orifice, we also place a 1 centimeter fully covered biliary metal stent, which we will then remove after 2 months and then see whether there's still recurrent tissue left. This patient is a relatively young patient, was 66 years old, so we'll look after 2 months, which is now in 4 weeks' time, and we probably have quite a low threshold to refer him to surgery. So in summary, endoscopic papillectomy is expanding the boundaries of endoscopic intervention. I think we've shown you that the long-term results are excellent, with a recurrence-free survival of 75% after 10 years, and also surgery survival of 80% after 10 years. I think this is the first line of treatment for papillary adenomas. However, you need to keep these patients long-term under control. And what are our biggest challenges nowadays? Well, that is that long-term recurrence. It's not like in duodenal adenoma. If you don't have a recurrence at 5 years, I think you can safely discharge these people. But as the adenomatous, or as the papillary tissue is still extending into the area where we have not done a resection, even micro residual tissue may cause a long-term recurrence. So, and radiofrequency ablation with a balloon has now been proposed as one of the options to do this, to extend this and actually do coagulating the orifice of the bile duct. It's difficult with those relatively small balloons nowadays, especially after you've put in a metal stent, to make sure the balloon actually touches the entire circumference of the bile duct. So I'm not sure RFA is the place to go. If you compare it to RFA of the esophagus, we have a balloon which is expanding and adapting to the size of the esophagus, and actually we need that in the bile ducts as well. Just an RFA balloon with which you cannot insufflate to a certain level of the bile duct, I don't think is not going to do the trick. And another big challenge, I think, are post-procedural bleedings, especially in these large combined duodenal and papillary resections. We have a relatively high amount of bleeding, up to 30%, and these patients are in hospital for at least 4 days. Mostly we can tackle these bleedings endoscopically, but it is really quite a challenge for them. So with that, I'd like to conclude, but not without inviting you to go to Amsterdam on December 15th. Again, you don't need to travel at all. Like I didn't come to Tokyo, you don't have to come to Amsterdam. But Amsterdam Virtual Live Endoscopy 2020 will have a full day from 9 to 4:15 European Standard Time. And well, you're happy. It's free registration, and we really hope to see many of you. So thank you very much, and I hope you're having some questions.
Yeah, very nice, comprehensive talk, Paul, as usual. Just a couple of questions. I will begin, and then I will hand over to host to ask a few more questions. First question is, previously, traditionally, it was thought that because it is almost mandatory now for us to place a pancreatic stent after ampulectomy or a papillectomy, it was always traditionally taught that we inject some diluted methylene blue in the pancreatic duct so as to identify the orifice of the pancreatic orifice after doing a cutting. So do you think this is still practiced or you don't require it?
Thanks, Amit. Excellent question. I don't think it's needed. Typically, when you do the amplectomy, or sorry, I'm still talking about ampelectomies and papilectomies. If you do the papilectomy, typically what you'll see at the end is a nice round biliary sphincter, and quite often a little bit of bile coming out. So you know exactly where the biliary orifice is, and then always a little bit to the right, a little bit hidden to the right, below or right, even a little bit higher, you can find the PD. So I think it's important to exclude a pancreatic device pancreas before, because that actually obviates the need for a stent, but otherwise I would not fuzzle around. And the same for the bile duct. You cut off the papilla and then you can almost always find your way.
Do you think an MRCP is essential before doing a papilectomy? Just to know the morphology of the pancreatic duct, whether there is an ANSA pancreas, suppose there is a looping, alpha looping, where you may not be able to place a stent after the papilectomy.
Yeah. We do it mainly to demonstrate a device pancreas, but you're right. You can have all kind of variants which will not be able to stent. So yes, we do an MR now almost always. And compared to a CT scan, I think MR gives much more anatomical information. The CT scan is mainly done when we have a high suspicion of cancer, and sometimes we do both.
And after you have done a papilectomy, if the report is malignancy, adenocarcinoma, so what is your next step? You subject them to a Whipple's?
Well, that's very interesting. That last case,
research?
Yeah, that last case I showed you, which was this this extension into the bile duct, etc., and it looked a little bit strange. Came back. That was a case from 3 weeks ago. Came back 2 weeks ago as a radically resected cancer, 6 millimeter. So what we saw in the biliary orifice was not a tumor anymore. This was a 66-year-old, otherwise fit patient, and I don't think we know a lot about the safety of radical resections of ampullary cancers. And in this case, there was also lymphangieinvasia. So I think those patients need a radical resection, meaning not just a endoscopic amplectomy, a surgical amplectomy, but you need a Whipple's procedure or pancreatic preserving, a pylorus preserving pancreatic duodenectomy. And he has been referred now. Yeah, I think there's, we of course like to compare now to what we do in early colonic cancer, but we have a lot of information about early colonic cancer that actually the risk of dying from it 5 years later is quite low. From ampullary cancer, we know that the 5-year survival is better than pancreatic, but still is, if we are lucky, around 40 or 50%. So I think it would be very risky in an otherwise fit patient not to do a radical surgical resection with lymph node dissection, and then you need this take out the pancreatic head.
Yes, Horst, would you like to ask anything?
Yes, I have, of course, the lecture was excellent, but I think we have to close the session, unfortunately.
Okay. So I'd like to thank everybody and my moderator, host Neuhaus, for conducting the session so beautifully. And of course, our speakers, Dr. De Beer and Dr. Paul Fockens, for doing a fantastic job and covering the topic so comprehensively. So any last words, Horst? You want to say something?
No, I would like to congratulate Aru Inouye and his organizing team for this outstanding conference. And it was a great pleasure also for me, and I think on behalf of all the speakers, to participate in this very interesting session. All of us learned a lot this morning in Europe and this afternoon in Asia.
And now we can go for breakfast.
Thank you. Bye.
Bye-bye.
Bye-bye.
Bye.